Topic is classification of periodontal diseases. Now we all know that any disease has to be classified. Now for the classification to happen, you need certain important personalities, or you need some kind of a academy wherein all people can sit together and decide what kind of classification system would be feasible to describe any particular disease or any particular or any group of conditions. Okay. Similarly, classification of periodontal diseases is very important. Now, why classification of any particular disease is important is because it helps us in diagnosis, it helps us in prognosis, it helps us in treatment planning, and then for a better communication with your fellow colleague, okay, or a medical or a dental professional. Now let's see, similarly, a classification of periodontal diseases also is very important. Now let's see the various classification systems that were put forward since 1989 to 1999. Now the 1999 classification is the most latest classification system and the classification system that we follow even now. If you see the 1989 classification, this classification system was put forward by American Academy of Periodontology World Workshop in Clinical Periodontics in 1989. Now, they categorized your periodontal diseases or periodontitis into various forms, into 5 forms. The first one includes your adult periodontitis, followed by your early onset periodontitis, periodontitis associated with systemic diseases, necrotizing ulcerative periodontitis, and your refractory periodontitis. Now if you see your adult periodontitis, this form of periodontal disease is seen most commonly in the age group greater than 35 years. And then you can also call the rate of progression of this disease is a slow rate of progression of the disease, and then there is no defect in the host immune response. But if you see your early onset periodontitis, as the term itself denotes, it's describing that the disease sets in at a very early age. That is, it is affecting individuals less than 35 years of age. And then there is a rapid rate of disease progression. And then also there is a defect in the immune response. Now this early onset periodontitis was subcategorized into 3 forms. That is your prepubertal periodontitis, your juvenile periodontitis, and your rapidly progressive periodontitis. Now you know that prepubertal periodontitis means to say that your periodontal disease, this form of periodontal disease, it's a form of early onset periodontal disease that affects individuals before puberty. If you see the next category, that is your periodontitis associated with systemic diseases or systemic conditions. Now here they say that again there is a rapid rate of periodontal destruction, which is it is associated with some kind of a systemic disease, some kind of a systemic condition. Now this systemic condition can be genetic in origin. Now this, for example, your Down syndrome, your Papillon-Lefevre syndromes, or Chidiac-Higashi syndromes, your agranulocytosis. So all these conditions are present systemically, and then it is expressing as periodontitis. So that's why they termed it as periodontitis associated with systemic conditions. And then comes the next category is your necrotizing ulcerative periodontitis. Now this form of disease is similar to ANAG, which is associated with attachment loss. You know your ANAG is nothing but your acute necrotizing ulcerative gingivitis. When it progresses to involve your attachment apparatus, other attachment apparatuses, then it will be called as your necrotizing ulcerative periodontitis. And then comes the last category, that is your refractory periodontitis. When you say refractory, it means to say a form of periodontitis that does not respond to any kind of treatment. That is, you do any kind of treatment, the patient is not at all responding to the treatment, and then he's still suffering from the periodontal diseases. Now this category is called as refractory periodontitis. If you observe beautifully, this classification has been mainly categorized according to the age of onset of the disease. Because your adult, they're calling it as adult periodontitis because it's seen in adults of greater than 35 years, and early onset because it's seen in less than 35 years. So basically they've subcategorized them into based on the age of onset of the disease. And then it was in 1993 that the European workshop said that we have to eliminate few of the categories which were there in 1989. They said that we don't need your periodontitis associated with systemic diseases and refractory periodontitis. So they have eliminated these two categories from the classification system, and they put forward a new classification which includes only your adult periodontitis, your early onset periodontitis, and your necrotizing periodontitis, with the similar features of what has been described in the 1989 classification, basically based on your age of onset of your disease. Now so they said that your adult periodontitis is mainly seen, the age of onset being the 4th decade of life, and then slow rate of disease progression with no defects in the host immune response. But then your early onset is seen less than the 4th, age of onset would be less than the 4th decade of life, with a rapid rate of disease progression with some defects in the host immune defenses. And then comes the last category, that is your necrotizing periodontitis, wherein they said there is tissue necrosis with attachment loss and bone loss. Then came up the new classification system, that is your 1999 classification system. Now, according to this classification system, which was put forward by the American Academy of Periodontology in 1999, they said that you can classify periodontal diseases just purely not on the age of onset, but you need to categorize them based on the rate of progression of the disease. So you have the new included terminologies, that is your chronic periodontitis and your aggressive form of periodontitis. So basically they felt that it is not the age of onset of the disease that is more important, but it is your rate of progression of the disease that is important, and then they categorize them into rate of onset depending on the rate of onset, and rate of progression depending on the rate of progression rather than the age of onset of the disease. Now if you see the classification, you can see in the slide that they've categorized them into gingival diseases, chronic periodontitis, aggressive periodontitis. Periodontitis is a manifestation of systemic disease, and the last category being developmental or acquired deformities. Now this is the only classification system that includes even your gingival diseases, whereas your other classification systems that we covered previously did never included any of the gingival diseases, right? They just covered the forms of periodontitis. Now let's go in detail about this 1999 classification system, which is a present classification system of periodontal diseases that we follow, and then let's go in a little bit about detail of each one of them, which is important, right? Now gingival diseases can be subcategorized into plaque-induced gingival diseases and non-plaque-induced gingival diseases, whereas your chronic periodontitis can be further classified as localized and then generalized form of chronic periodontitis. Your aggressive periodontitis again can be subcategorized as localized and generalized. Your periodontitis as a manifestation of systemic disease can be subcategorized into necrotizing periodontal diseases, abscesses of the periodontium, and periodontitis associated with the endodontic lesions. And then the last category, that is your developmental deformities or conditions, can be or acquired deformities, can be categorized into subcategorized into 4 types. That is tooth-related factors or tooth-related local contributing factors, mucogingival deformities around the teeth, mucogingival deformities around the edentulous ridges, and occlusal trauma. And if you see the gingival diseases, the first subcategory is your dental plaque-induced gingival diseases. Under this, there are 4 subheadings, that is your gingivitis associated with dental plaque only, and then you have gingivitis modified by systemic diseases, modified by systemic factors, modified by medications, and then gingival diseases modified by your malnutrition. If you see gingivitis associated with dental plaque only, they're again subcategorized into your with local contributing factors and without local contributing factors. The second subcategory is your gingival diseases modified by systemic factors, which includes the ones associated with endocrine system and the ones associated with blood dyscrasias. The ones associated with endocrine system are puberty associated gingivitis, menstrual cycle associated gingivitis, pregnancy associated gingivitis, and diabetes mellitus associated gingivitis. The pregnancy associated gingivitis can produce a generalized gingival condition or gingivitis, whereas it can lead to a localized inflammation of the gingiva, which is called as your pyogenic granuloma. Now, if it is associated with blood dyscrasias, what are the blood dyscrasias that can cause gingival diseases? That is, one of the important one is your leukemia associated gingivitis and others. Now, the gingival diseases modified by medications include the drugs that influence gingival diseases include your ones which cause gingival enlargements, the ones influence gingivitis, and the oral contraceptives associated gingivitis and others. So the drugs that are influenced to cause your gingival enlargement include your anti-epileptics, your antihypertensives, especially your calcium channel blockers, and then your immunosuppressants like your cyclosporin and tacrolimus. If you see, the gingival disease is modified by malnutrition, especially it includes the one which is because of ascorbic acid deficiency, that is your vitamin C deficiency, which mainly produces something called as soggy gums, right? And others. Now, what are the non-plaque induced gingival diseases? You have the ones of specific bacterial origin, the gingival diseases of specific viral origin, the ones with specific fungal origin, and the ones with genetic origin, the ones as a manifestation of systemic diseases, and the third last one being your traumatic lesions, the ones with foreign body reactions, and the ones which are not otherwise specified. The lesions which occur but you can't categorize them into anything else, so you put it under not otherwise specified. So if you see the ones of bacterial origin, these are the organisms like your Neisseria gonorrhoeae, Treponema pallidum, Streptococcus species, and others. Of the viral origin would be primarily your primary herpetic gingivostomatitis caused by your herpes virus, varicella zoster, and then your recurrent herpes and others. The ones of fungal origin include your Candida species, your linear gingival erythema, and then histoplasmosis and others. The ones of genetic origin would be your hereditary gingival fibromatosis and others. The ones of manifestations of systemic disease include the ones of mucocutaneous conditions like pemphigus vulgaris, pemphigoid, bullous pemphigoid, erythema multiforme, lupus erythematosus, etc. And then your allergic reactions, the one to your dental materials or restorative materials, maybe to mercury, it can be to nickel, it can be to acrylic or any other dental materials. And then your reactions attributed to your toothpaste, dentifrices, mouth rinses or mouthwashes, chewing gum additives or any other additives into the food, or food itself can produce some reactions and lead to some kind of a gingival disease. Now, and others. Now, if you see the traumatic lesions, these traumatic lesions of the gingiva can be because of some physical injury, chemical injury like chemical burns or like aspirin because of the drugs, or it can be a thermal injury like a pizza burn or anything else. And then second last is your foreign body reactions, and then not otherwise specified. Now, if you see these are the gingival diseases. Now, let's see your chronic periodontitis. A chronic periodontitis can be subcategorized into localized and generalized form. You call it as localized chronic periodontitis when 30% or less than 30% of the sites are involved with periodontal disease, whereas you call it as generalized chronic periodontitis when greater than 30% of the sites are involved with the disease. Apart from that, you can also classify your chronic periodontitis into slight or mild periodontitis, moderate periodontitis, and severe periodontitis. You call it as slight or mild when the clinical attachment loss is just about 1 to 2 millimeters. You call it as moderate when the clinical attachment loss is about 3 to 4 millimeters, and you call it as severe chronic periodontitis when the clinical attachment loss is greater than or equal to 5 millimeters. When you see your aggressive periodontitis, they're again subcategorized into localized and generalized. Now, you call it as localized aggressive periodontitis when there is attachment, interproximal attachment and bone loss, which affects at least 2 permanent teeth, which includes your first molars and incisors. Okay. And then you call it as generalized aggressive periodontitis when there is an interproximal bone loss in at least 3 permanent teeth other than your first molars and incisors. Okay, so that completes your entire classification system of periodontal diseases. Thank you. The topic is the drugs that are used in periodontal therapy. Now, what are the drugs that are used in periodontal therapy? You can classify various forms of drugs that are used or incorporated into the regular periodontal therapeutic procedures. Now, you know periodontal therapy, just the mere mechanical control of the agents or the local factors is just not sufficient enough in some cases to overcome the bacterial challenge. You know the main etiological role of for your periodontal diseases is the bacteria. So in order to reduce the load of the bacteria, certain drugs have been incorporated into the periodontal therapy. Apart from being just your incorporated just for the reducing the load of bacteria, they've also been incorporated to modulate a bit of the host response. let's classify what are the group of drugs that are used for the periodontal therapy. Now you can classify them as anti-plaque agents or anti-calculus agents, and then you have your antibiotics, and the last group will be your anti-inflammatory drugs. Now each of this, let's go in detail. First, the anti-plaque agents and your anti-calculus agents. Now, you can classify your anti-plaque agents into first generation, second generation and third generation agents. Your first generation agents have the capacity to reduce the plaque just to about 20 to 50%, and they lack the substantivity. Example would be your sanguinaril. You have your second generation agents, which include your chlorhexidine or the bisbigonides, which have a good substantivity of about 12 hours, meaning they can retain or they can stay on the attached to the tooth surface and the tissue surface for a period of 12 hours. So just twice daily use of chlorhexidine would be sufficient enough to produce all its effects. Okay, and then apart from that, they also, the second generation, they reduce the plaque score to about 70 to 80% or to 90%. Okay, and then coming to the third generation agents, which include, example will be your delmophenol. What are the group of antibiotics that are used in the daily or incorporated into the periodontal therapy? Now you have certain terminologies. Before you know in detail what are the antibiotics, we should know certain terminologies that are used to describe any of the antimicrobial drugs. Now what are the antibiotics? What are chemotherapeutic agents? A chemotherapeutic agent is it's an active chemical substrate or chemical substance that produces some therapeutic clinical benefit. What is an antimicrobial agent? An antimicrobial agent is a form of a chemotherapeutic agent that reduces the amount of bacteria or that specifically targets the bacteria or certain organisms or by reducing all the bacteria. Now, what is an antibiotic? An antibiotic is a form of an antimicrobial agent which is either produced by the microorganism or it is obtained from the microorganism that have the capacity to kill the other microorganisms or inhibit their growth. Now your chemotherapeutic agents into periodontal therapy can be given either as local agents or they can be given as systemic antibiotic therapy. So administration can be local or systemic. When we see about systemic administration of antibiotics, now what is the importance? Now they reduce or they eliminate the bacteria that cannot be removed just by mere scaling and root planing. And then they decrease the plaque and gingivitis, and then they retard the bone loss, and they're most of the time used in conjunction with the non-surgical therapy, and then they reduce or eliminate the need for periodontal surgeries. They also incorporated in treatment of aggressive periodontal diseases. What are the advantages of systemic medication? They have an effective tissue invasive property. They are and they kill the microbes which have invaded or penetrated the tissues. Apart from that, they take less time and then they are quite inexpensive mode of therapy. They treat multiple sites simultaneously, and acute conditions like UNUG can be treated with or they need the supplemental antibiotic therapy. As a pre-medication for patients, your systemic antibiotics can be given. For example, a patient with infective endocarditis comes to you for a periodontal treatment. You know that the patient is suffering from endocarditis, infective endocarditis, so you better give him an antibiotic prophylaxis. When you see the local administration of antibiotics, the advantages include a greater concentrations of this drug are achieved at one local area. Okay, and then the systemic side effects are reduced because you are incorporating the drug at a local site. They are slow releasing devices which have the advantage of releasing the antibiotic gradually. So you have placed a local drug delivery or local into the pocket, and then this drug slowly releases the drug that is incorporated into it within a period of time. So you have an expanded mechanism of action for a longer duration of time, and then their effect can be directed to specific target area. Now you know the target area is supposed to be forceps. You place a local drug delivery in the forceps, so that specific target area is covered to treat the periodontal site, diseased site. What are the most commonly used antibiotics? You have tetracyclines, you have metronidazoles, you have penicillins, you have ciprofloxacin, and you have clindamycin. What are tetracyclines? They are antibacterial agents, or they have multiple functions. They are a group of antibiotics which have multiple functions. They have an antibacterial action, they have an anti-collagenollytic action, they inhibit bone resorption, they are anti-inflammatory actions, and then they enhance fibroblast attachment. Now, your inhibition of bone resorption is caused by the anti-proteolytic, that is your anti-collagenollytic, and your anti-resorptive activity. They inhibit the bone by bone resorption, which is induced by your parathyroid hormone and prostaglandin E2 series and bacterial endotoxins. You know, one of the most important property of tetracyclines is that the concentration of this tetracycline in the GCF is about 2 to 10 times than that in the serum. What are the specific agents and their dosage? Now, you have lots of modifications of tetracyclines, which include your minocycline and your doxycycline. Now, the tetracycline dosage would be about 250 milligrams 4 times a day. So, taking a tablet 4 times a day would be more uncompliant for the patient. So, the patient won't be able to take 4 times a day. He might not even remember. Therefore, the newer advances, that is your minocycline, which is 200 milligram dosage, is given twice a day for just 1 week. And then doxycycline is much more better. You have just 100 milligram of the drug just once daily, twice on the first day, and just once daily for about 4 days. The next group of antibiotic is your metronidazole. You know, metronidazole is a gram. It's a narrow spectrum antibiotic, and it is bactericidal, especially to your anaerobes. Now, it disrupts the bacterial DNA synthesis. Clinically, it is used to treat necrotizing ulcerative gingivitis, chronic periodontitis, and even aggressive form of periodontitis. The dosage includes 200 milligrams and 400 milligrams, which is available, and you have to give it 4 times, 200 milligrams 4 times a day for 1 week, and then 400 milligrams 3 times a day for 1 week. Now, coming to the next group of antibiotics, that is your penicillins. You know, your penicillins are a broad spectrum antibiotics, and then they are bactericidal but induce allergic reactions. You know, they have the capacity to inhibit the cell wall synthesis. The penicillin, the most important group, will include your amoxicillin. Again, this is a broad spectrum activity, and it is useful in patients with refractory or juvenile or aggressive form of periodontitis. The dosage that you give is 500 milligrams 3 times a day for about 1 week. Augmentin is a modification of this amoxicillin. In order to make the availability of amoxicillin better, you have a clavulanic potassium, which is added to amoxicillin, because the beta-lactamase is an enzyme produced by the bacteria, which have the capacity to break down the beta-lactam ring of your antibiotic, that is a penicillin. Therefore, they have incorporated clavulanic acid potassium into your amoxicillin, which is useful in patients with an aggressive form of periodontal diseases. What is the dosage? It's available in 2 forms. You have Augmentin 325 milligrams, 375 milligrams, and 625 milligrams. The 375 milligrams of Augmentin contains about 500 milligrams of amoxicillin. 250 milligram of amoxicillin and clavulanic acid of 125 milligrams thrice a day for about 1 week. Your Augmentin 625 milligrams has 500 milligrams of amoxicillin and 125 milligrams of clavulanic potassium, which may be given twice a day for about 1 week. Now, let's see about ciprofloxacin. Your ciprofloxacin, again, it's active against gram-negative rods. The minimal effect on Streptococcus species. At present, ciprofloxacin is the only antibiotic which is effective against all the strains of A. comitans. That is your Aggregatibacter actinomycetum comitans. And then comes clindamycin. This acts against the anaerobic bacteria and is effective in patients with refractory periodontitis. It is associated with pseudomembranous colitis. So, overusage of clindamycin can cause pseudomembranous colitis. Coming to the next group of drugs that are used in your periodontal therapy, that is your non-steroidal group of anti-inflammatory drugs. Now, you know the normal synthesis of prostaglandins, or you know any cell contains an outer layer called as your phospholipids. So, your outer layer is composed of phospholipids, right? So whenever there is an injury, what is happening is there is synthesis your phospholipase. Under the enzyme phospholipase influence, your phospholipids are broken down to produce your arachidonic acid. Now this arachidonic acid, under the influence of two enzymes, your lipooxygenase and your cyclooxygenase, will produce two different pathways. You have your cyclooxygenase pathway and you have your lipooxygenase pathway. Through the cyclooxygenase pathway, what you get are your prostanoids, that is your prostaglandins, and then through the lipooxygenase pathway, you get something called as leukotrienes. Now this NSAIDs have the capacity to block the synthesis of prostaglandins, meaning they block the cyclooxygenase enzyme, thereby preventing the conversion of your arachidonic acid to your prostaglandins, because prostaglandins are one of the important inflammatory mediators, and then they mediate your bone resorption process. So if you can control if you can block the cyclooxygenase and prevent the synthesis of your prostaglandins, then your bone resorption can be taken into control. The most important drugs that are studied under NSAIDs include your florbiprofen, ibuprofen, mefenamic acid, and naproxen. Now let's go in detail to the local drug delivery systems. Now what is this local drug delivery system? They're basically you're incorporating a drug locally in order to treat, because you know your periodontal diseases are site-specific diseases. When you say it is site-specific, you have to treat that particular site rather than just incorporating a systemic kind of a drug which will produce lots of systemic effects. But if you can incorporate a drug to the local area, probably it would be more advantageous. Now that's why with this thought, a lot of local drug delivery systems have come into place. Now this local drug delivery systems have a limited efficacy of mouth rinsing. Because of the limited efficacy of the mouth rinsing and irrigation in deep periodontal pockets, now this led to the development of alternative delivery systems. The main aim of the drug delivery system includes to direct the antimicrobial agent to the infection sites. Now you know that your just mouth rinsing and irrigation, subgingival irrigation, will not expect, you can't expect the entire drug to reach the base of the pocket, and then the substantiality of the drug is not of long. Probably it will just, if you're going to use chlorhexidine, it probably stays for 12 hours and then it doesn't act. You have to keep repeatedly using it, and you don't know the depth of penetration of this mouthwash. So with these limited efficacies of these drugs, you have alternative methods which have come into research, and then they've come up with the local drug delivery systems. The main aim being to direct the antimicrobial agent to the infection sites. Apart from that, the other aim is to maintain the effective level of the drug within the site specific, so that for the sufficient period of time you can have the antimicrobial or the drug in place for a period of time. What are the indications for local drug delivery? The first indication being you can use it as an adjunctive therapy in treating localized non-responding sites. So the sites which are not responding to any kind of periodontal treatment, probably you can incorporate an adjunctive mode of therapy in these sites through local drug delivery. Apart from that, ailing and failing implant cases, you can also place local drug delivery systems. In medically compromised patients, you can't give them any kind of you won't be able to do a proper surgical procedure because you're limited to the available options. Therefore, you can think of doing more simpler, a conservative approach of doing the local drug delivery. Then periodontal abscess. Now you can treat a periodontal abscess by incorporating a local drug delivery. And then periodontal maintenance. As a part of maintenance therapy, you can use your local drug delivery systems. Patients with GI intolerance to systemic antibiotics can be given local drug delivery systems. What are the advantages of using this? High concentrations of the drug can be achieved at the subgingival sites. They are independent of patient compliance. You need not have the compliance of the patient. You need not follow up the patient thinking whether he's taken the antibiotic, has he taken the entire dose of it, is he continued for the prolonged the time period that you have given him. You don't need to focus on it. So the basic advantage is it is independent of patient compliance. Apart from that, it does not harm the symbiotic useful microflora of the GIT. You know, some of the antibiotics, reduce the normal gut flora. For example, your lactobacilli, which are present in the gut flora or the intestinal flora, are reduced by certain antibiotics like your ampicillin and amoxicillin. So now these drugs can be stopped. Now your local drug delivery systems can prevent this because they are not entering the systemic circulation. Then the individuals who are intolerant to systemic drugs, now these can be bypassed. So let's see the vehicles for this local drug delivery. The vehicles can be your dentifrices, your mouth rinses, your chewing gums, slow release devices in the form of fibers, chips, microspheres and hollow tubes. Now what are these slow release drug devices or controlled release delivery systems? They are designed to release your chemotherapeutic agents into the periodontal pocket over an extended period of time, and hence they can achieve high levels of concentrations at the sites where they are precisely needed. Classification: you can classify them as reservoirs without a rate controlling system, which include your hollow fibers, and then gels and dialysis tubings, whereas you have the other classification, that is the reservoirs with a rate controlling systems like your polymeric matrices, your polymer membranes, and then your monolithic matrices and etc. They are effective for more than 24 hours, whereas reservoirs without a rate controlling system, they are effective for less than 24 hours. What are the methods of delivery of your chemotherapeutic agents? You have the case technique, like through your the dentifrices can be incorporated as a local drug as a delivery system through your dentifrices, mainly through your toothbrushing. And then root biomodification, that is you can modify the root surfaces you can remove the smear layer and the endotoxin layer on the root surfaces by incorporating certain agents like your EDTA, your citric acid, your tetracycline and etc. and fibronectin, growth factors, etc. The irrigation devices like the home irrigation devices and the professional subgingival irrigation. The home irrigation devices include your supragingival home irrigation devices, subgingival home irrigation devices and marginal home irrigation devices. What are the currently available local drug delivery systems for periodontal therapy? You have your doxycycline in the form of Atrodox, which is a bioresorbable, and it is available in the form of mixture in a syringe form. And then your tetracycline, again it's the trade name is Acticide, and it is a non-resorbable one, and then it is available, or the vehicle is the fibers. Metronidazole, the trade name is Elizol, and it is a resorbable one, and it is available in a syringe form. The minocycline also available in 3 forms, that is your Arestin, dentamycin and your periocline, which are all resorbable or bioresorbable ones, which are again available. The vehicle form would be in the mixture in a syringe form. Then chlorhexidine, the trade name would be Periochip, which is again the nature would be biodegradable, and then it is available in the form of a chip. Thank you. That would complete that will bring us to the end of local drug delivery systems and your drugs that are used in periodontal therapy. Thank you.